Good evening and welcome to this UKFPO webinar about GP as a career, pathways, possibilities and perspectives. My name is Dr. Mike Masding. I'm National Clinical Director of the UKFPO. I'm a secondary care physician and I have spent all of my career really working in hospitals. But I think it's really important that we hear about general practice as a career, because actually, even as a secondary care physician, I spent an awful lot of my time interacting with GPs, whether that's talking to them on the phone, writing them letters, often of which I suspect they think are far too long, and discussing patients and their care. So I think just about every specialty comes into contact with general practitioners at some point. And of course, many of you will have seen your GP recently about healthcare. In the NHS, general practice has been described as the jewel in the crown. And indeed, general practice as we know it is not really present in many other countries around the world. We've got a panel of 4 GPs, all at different stages of their career and who do different things. And hopefully they're going to give you some different perspectives and about the different opportunities that are available if you were to take a career in primary care. We've got Dr. Molly Deneen, an ST3 training to be a GP, who is also an academic clinical fellow and does some work with the Royal College of General Practitioners. We've got Dr. Aisha Tuzara, who's head of school for GP in the east of England. Dr. Pavan Upal, Patch Associate GP Dean in the south of England, in Kent, Surrey and Sussex. And Dr. Chris Mayer, who's GP Assistant Director in East and South East Scotland. I'm very grateful to them all for giving up their time to take part in this webinar, and I hope that you will find it enjoyable. There is the opportunity to ask questions if you put them into the Q&A tab on this Teams broadcast. And of course, this will be recorded and put onto our website and our YouTube channel for people to look at a different time. The format of this is, rather than having lots of slides and data, we're actually going to talk about how it is to be a GP. And I'm sure I'm going to learn a lot through asking questions of our panel members. I'm going to start with Molly, who is based in Bristol. Molly, as someone coming towards the end of your GP training, what originally attracted you to a career in primary care?
Yeah, thanks, Mike, and hi, everyone. So I think really I always knew deep down that I wanted to be a GP, and there are lots of reasons for that. One reason was that I liked a bit of everything, so I think I couldn't imagine myself narrowing down and picking a single specialty. I really valued continuity with the patients that I was seeing. I was the person on the wards that wanted to go back to the same bay every day and see the same patients. And I slowly realised that actually being in general practice, I'd get that longer term continuity. I always was trying to look up in the hospital what had happened to my patients. And I like the idea in general practice that you get to follow things through. I like the variety, not just of the kind of presentations, but of the patients, being able to see young patients, old patients, and the real mix of demographics. And I like the prospect of being able to combine general practice with other interests. So from an early stage in my career, I've had an interest in research and leadership. And I think I felt that general practice would be a really good place to combine some of those interests and kind of create a kind of schedule in the week that suited me with lots of different things going on. And that you can do that in lots of specialties, but I think general practice is particularly good at allowing you to build kind of your own career path. So yeah, there are lots and lots of things that attracted me to general practice. Fortunately, all are proving to be true and all are proving to be things that I'm enjoying training to be a GP. And yeah, that's really the main things that led me towards general practice.
Excellent. And you mentioned about being an academic GP. I suspect many viewers, particularly if they're early in their career, may not know that that's an opportunity to be an academic GP. Can you describe the sorts of things that you do in academia when you're a GP, and what's good about that role?
So being an academic GP means that during your week you spend some time in clinical practice, but that you also spend some time in academia. And for some people that can mean in medical education, so delivering teaching. But for me, that means doing research. So what I'm doing is designing my own research questions, going out and delivering my own research projects, and then bringing together some of the findings and applying that to general practice and my own practice, and hopefully to influence policy changes and things like that. Being an academic GP trainee just means that from a very, very early stage, so right from my GP training, I'm building that combination. And I feel very fortunate to be able to do that at a very early stage in my career, because it can be slightly harder to get into those things once you're an established GP. So right from the very beginning of my training, I'm doing a balance between clinical training and research training. And hopefully that means I can carry that combination through my career. And my interest at the moment is in continuity of care. So I'm doing lots of research about the different access models and systems that we're using in general practice, and how we can deliver continuity in our practice with the kind of current demands that there are in the current world. And I find that really rewarding, because I can find some problems that I'm coming across in general practice, and I can go away and try and answer the questions and then hopefully bring them back into my practice. So it's really rewarding. It's almost like therapy to me, a way of going and dealing with the things that come up in my day-to-day life as a GP. So I really enjoy that combination, and getting into it right at the beginning is a really positive thing, I think.
And as far as I'm aware, most, if not all, medical schools have academic departments of primary care. So it's an opportunity that's available just about everywhere, I guess.
Yeah, absolutely. So there are some kind of main centres in the UK that deliver kind of primary care research, but you're right, all over the country you can access these opportunities. And so when you start thinking about applying to your GP training, it might just be worth having a look at the opportunities for academic training. And you apply in a slightly different way, but ultimately you join the same cohort of people, just with this added extra.
Now, you mentioned there the GP training pathway. Tell viewers about how one goes about training to be a GP.
So once you've finished your foundation years and you've decided that you want to be a GP, then you need to apply to the general practice training scheme. And that's a 3-year training program, and it's a run-through program. So you apply at the beginning and you'll stay on it all the way to the end as a GP. And so unlike some specialties, there's only kind of one entry and one exit, which is really good. Once you're in, you're in. You don't have to reapply or change locations or anything like that. And it's a 3-year program. You'll spend some time in the hospital just getting some specialty knowledge in areas that are particularly helpful for general practice, things like paediatrics, obs and gynae, all sorts of specialties. And then you'll spend some time in general practice. And you'll get hopefully at least the experience of 2 different GP practices while you're in your training. And you get really dedicated training to be a GP at this stage. So each week you'll have teaching with your kind of cohort of GP trainees. You'll have a dedicated supervisor. And I found that at that point I was getting really, really good training to be a GP. So yeah, really dedicated training. If you did want to decide to do something like academic GP training, or kind of one of the other kind of slightly different models, it might be 4 years. But equally that time flies by so fast. So it's important to pack in that time. But yeah, it's a hopefully fairly straightforward program. You can do it all over the country, but it is getting increasingly competitive as it's the best specialty.
Of course. And what about exams? What exams do you have to do during your GP training?
There are a couple of exams, no avoiding that. So there's one exam to get into GP training. So there's just a it's an online kind of multiple choice question test and situational judgment to get into GP training. And then when you're in, there's 2 big exams. One is a clinical knowledge test, similarly done online, multiple choice questions. And then one simulates a kind of normal surgery. So you're seeing 12 patients, 12 consultations, they're all videoed, and then you get examined on those. And that's right at the end of your training. And by that point, it will be second nature. So hopefully you'll be ready to kind of deliver that kind of consultation style. But they're very practical exams, especially that second one is very good to just make sure you're up to speed and ready to be a GP. And I must say, it doesn't feel too burdensome during GP training. They feel like very kind of reasonable exams to do. But yeah, there is an element of a portfolio as well that you have to keep up. So lots of reflections on cases that you're seeing, demonstration that you're doing some leadership kind of events, that you're doing some quality improvement, similar to what you'll have done during foundation program. So it's a fairly busy time. There's lots to be doing, but really just replicates what life would be like as a GP, really.
And of course, all specialties have to do exams, so GP is no different to that. But don't imagine that any specialty doesn't do exams; they all do them. And tell me about working as a GP in an urban area. What are the pros and cons of working in a big city like Bristol?
Yeah, so Bristol is a big city, lots of variety, the sorts of demographics that we're seeing at the moment. I'm working in what's called a deep end practice, so serving kind of the most socioeconomically deprived patients in Bristol. And yeah, working in an urban environment comes with its challenges. There's really high patient demand. You know, some of the patients have real needs that we need to serve. You know, really diverse patient group, a lot of whom don't speak English as their first language. There's all sorts of challenges, but with that comes a huge amount of learning, lots of experience of working with different patient groups. And for me, it's just huge variety, which I really like. So it's a really, really varied day dealing with patients in a kind of an urban population. So that, yeah, pros and cons. I've also actually worked in quite a rural environment as well, and it's really good during a GP training to try and get a mix if you can. But I think working in a big city environment brings lots of opportunity, be that for research or teaching or leadership, as well as the kind of patients that you get to work with. So for me, it's just been an exponential learning experience, but it can be that bit more challenging, perhaps, just because of that increased demand.
And by definition, working in primary care, you have all of those different options of working in rural areas. And I'll ask Chris a bit more about that a bit later, working in urban areas. Whereas by definition, if you work in a hospital specialty, particularly sort of the more specialised you get, you will be in an urban area because that's where hospitals are. So yeah, a lot more variety around primary care. Thanks, Molly. Really, really interesting to hear about being an academic GP and the opportunities that are available there. And I hope some of our viewers may provoke some thought about some of those things that you could do. Thank you very much. I'm now going to move on to Aisha, who's based in Ipswich in the east of England. Good evening, Aisha. Tell us about your career pathway and how you've ended up doing what you do.
Thank you, Mike, and good evening to everyone. So just Molly, like Molly, I did my GP training in East of England in Bury St Edmunds. In 2006, I started as a trainee and had a similar pathway, but was slightly longer than Molly because I had 2 maternity leaves during it. So I had that flexibility as a trainee. I could do that. Once I completed my training in 2011, I just really wanted to explore what was available, and I decided to take on a salaried GP role in a practice where I was trained. And that was really good for me because I could consolidate my knowledge and explore what is out there. I did some locums within the same practice at times because I was doing 6 sessions. And then I felt that I really wanted to get involved into teaching. So that's where I became a GP trainer. And that took me on to explore further things. So I think just becoming a GP opened lots of avenues and opportunities, and my career pathway took me from a salary to a partner at a big practice of 30,000 patients, and then now as a head of school at various stages. I won't focus on my educational journey a lot because Pavan is going to talk about that a bit later. So that's where I am as a GP working as a partner in a practice.
Now, it's a good opportunity to talk about being a partner, which is, of course, something that absolutely doesn't happen if you're in a secondary care specialty. Tell us about being a partner, Aisha, the sorts of commitment you need for that and what sort of opportunities it brings.
I think with commitment, it depends whether you're a full-time or a part-time partner. So I'm a full-time partner from the very beginning, which is 8 sessions. So it's spread over 4 days rather than 5 days. So you have got 1 day to yourself or to do other things. It is basically a self-employed partnership model where you can own the premises, you cannot own the premises, depending on which partnership you're going into. You sometimes have to put in a little bit of capital. Again, that is changing. But it just allows you to work very differently to as you would be working as a consultant. You're basically self-employed. You've got a list size of patients. You're working with group. Like for us, I said 30,000. So NHS England provides the funding for those patients, and we manage it as a group of partners, how we run the practice. So that gives you opportunities where you could if you've got interest in doing some HR work or management work, and other working with developing a team. So it just opens a lot of things for you, where it gives you a bit more control on how you can shape the practice within your own practice, rather than being told, not, I won't say in hospital consultants, I'm sure you've got some autonomy as well, but as partners, we've got more autonomy on how we can support our staff, how can we support our patients, and a bit more. So I think it's a different world for partnership. It comes with its own responsibilities and risk as well, because obviously if you're owning a business, then it's got its own liabilities. But it's a very successful model, and it's unique to England and Scotland, United Kingdom. So it is working really well across the patch at the moment.
Okay. You mentioned about education, and Pavan is going to talk about that in a bit. What other opportunities are there if you're a GP, sort of outside of directly seeing patients?
I would say it's endless. And I think that's where I didn't cover in the first question. So when I had that one day off, I decided what I wanted to do. So because I was partner, I could negotiate with my colleagues, and I decided to go into commissioning world. So I worked with the clinical commissioning, and now called integrated care boards, for 1 day a week for about 7 years. And that allowed me to see how the policies evolve, how you implement things, how commissioning happens, how contracts happen. So it was an interesting world completely. Other than that, GPs can be locum, they can be portfolio GPs where they can do their own things like doing appraisal work, or GPs with extended scope of practice where they can do dermatology, they can do frailty, end of life, continuity care, a lot of things. So I think the opportunity, and academics and research, like Molly said. So there are so many things out there when you're a GP. I just feel the opportunities are endless. It just depends how you want to mold your own week, and how supportive your practice is, which mostly are, and then you can develop a lot within that 1 week and take it forward.
And how do, if you did want to be a general practitioner with that special interest, and you mentioned dermatology, end of life care, that sort of thing, how is that something that just naturally evolves, or is there a sort of pathway for that?
I think I would say it naturally evolves. My advice would be that first 2 years after your qualification, you just need to consolidate your knowledge as a GP, and once you explore and develop, say, for example, I like skin, then there are local training hubs within each ICB or within each patch where you're based, and they can support you with the pathways where you could do a diploma in dermatology, you could do a diploma in lifestyle medicine, you can do diploma in elderly care, and then you can follow and develop further sessions within the practice. Or we have got some GP with special interest working for the hospital just to support the consultants. So there's a lot more opportunities when you've done further. Family planning is another thing, women's health, menopause. So there are so many opportunities that you can explore whatever you want to do.
That's brilliant. So it's really clear that if you dedicate yourself to going through the GP training pathway, it doesn't just mean you're going to do lots of GP surgeries, although you can do that. There is also the opportunity, lots and lots and lots of other opportunities and flexibility around that. What do you enjoy, Aisha, in your GP work? What makes you?
Yeah, so I think so a variety of things. So I think my week is spread. So I do some clinical work, I do some management work, I do some educational work, I do some I used to do some CCG, but it was getting too much, to fit in, and you had to choose what I enjoy. So I've decided to stick to education and leadership, because I think that gives me a lot more opportunities to develop further. And also, I forgot to mention, local medical council is another. If you're really into, if some of our colleagues are into BMA, they would appreciate, they would want to take that career forward, they could join the local medical committees as well, LMC, and develop that. So I think I would say I probably enjoyed the educational and clinical work.
Good. Well, thanks, Aisha, and really interesting perspectives. And it's good to hear about being a partner, which, as I say, people in secondary care would have very little knowledge of. And it's something for our viewers to have a think about, and whether that's a path they want to go along. Thanks, Aisha.
Thank you.
I'm going to move on to Pavan now. Good evening. Pavan, and you have worked as a salaried GP and a locum GP. Can you just explain to viewers, how that sort of works and what the benefits of those sorts of roles are?
Yes, of course. Thank you, Mike. So when I first CCT'd, I stayed as a salaried GP in my training practice that I'd been an ST3 in. So salaried is when you actually are employed by a specific surgery for a certain number of sessions a week. And we've increasingly seen newly qualified GPs wanting to have flexibility within those sessions to be able to do other things as well. But the good thing about being salaried is it gives you a home, it gives you a base. It's really nice to, in particular, stay in your training practice because it helps bridge that gap between being newly qualified, transitioning from having just CCT'd, and it gives you that you're still sometimes with your trainer and the colleagues who were supporting you when you were still in training, but also it sort of gives you that soft landing into those first sort of 6 to 12 months being a new GP. But then, as I said, it gives you that base to then start exploring and thinking about if you do want to have some sort of portfolio career, what are the options, what makes you tick, what's going on in your local area, what connections are there. And as a salary GP, I just took every opportunity that was going, whether it was getting on a clinical supervisor pathway. I undertook a dementia fellowship. I led on our vulnerable children's meeting locally because I've got a special interest, clinical interest in domestic abuse, which then developed over the next few years over that across my patch, East Surrey. But also just really great and very varied things in my working week, such as visiting boarding schools. We've got 2 local boarding schools, being the name doctor for a residential home, a nursing home. So just, yeah, actually, when I was preparing for this webinar, I was looking back at everything I did, and I was like, wow, I forgot about that. That was so fun. But those early years just start to develop you and your interest to see what makes you tick, but also what your future career could look like. So I've been very lucky. I've been salaried in a few different practices across Surrey and Sussex, and I had a period of mat leave and came back from that, and I was still salaried, but then decided to switch to locuming, and that really was to try and balance out some of my medical education roles, which I really enjoy as well. And the great thing about locuming is I think once you're established and you feel more confident as a working GP, it gives you that flexibility. So I can choose when I work, where I work, how often I work. If there's a conference I really need to go to, I don't have to sort of juggle annual leave or study leave around that. So it gives you that flexibility to do things on your terms as well. So yeah, lots of things.
I mean, that sounds amazing from a secondary care perspective, I must say, to have that flexibility. And it strikes me already, 20 minutes in, just how many different strands of work we've heard about that one can take on as a GP. And one of those, of course, is medical education, which we've mentioned a number of times. Tell me about your journey to becoming a medical educator in GP.
Yeah, thanks, Mike. When Aisha was speaking, I was thinking it's probably easier to list the things you can't do as a GP rather than the things you can, because the list is endless. So I was really, really lucky to, as I say, be trained up as a clinical supervisor, and through that I had the opportunity to complete a PG cert in medical education through our deanery, Kent, Surrey and Sussex. And as I mentioned, I had a little break from mat leave and sort of reassessed. Again, you have those moments where you think, well, what is it that what do I actually, with all these opportunities, what is it that really makes me tick? And I absolutely love to teach. I've always loved to teach. Just it's I don't feel like I'm working when I'm doing it. And actually, there's lots of skills we take from being a GP that are transferable to teaching and medical education. So then I started off as a training program director in the scheme that I trained in, which is lovely. And I did that for a few years. It was during COVID time, so we had to be quite agile and look at how we could move things online and do things differently. So I really enjoyed that challenge. But also I've got some other roles beyond the GP school. So I'm a GP tutor, so that's more looking at post-CCT and the whole primary care workforce. But also I've done a lot of work to support international medical graduates and looking at differential attainment. And I've set up and lead on our local AKT support program. That was one of the exams that Molly was referring to. So we run the CAST program in KSS. And again, I was really lucky to be able to be given the opportunity to undertake a master's. So I looked around what factors helped international medical graduates pass the AKT, and that work's been published. So I'm really proud of that as well. And in the last year, I'm now a patch associate dean. So again, in the area that I trained in, which is amazing. I'm just been really lucky, and I'm hopefully in a few weeks starting another associate dean role, looking at the expansion of GP training, because we're only getting bigger and better, and looking at everything that brings as well. So yeah, the opportunities are endless for medical education. So yeah.
Fantastic. And a question I was going to ask, but it just popped up in the questions from Inor, who has probably phrased it better than I did, to be brutally honest. So well done. Are there any specific things that we can and should focus on in the foundation program in order to increase our chances of landing a GP specialty training position? Is it as hard and competitive as it seems? Any advice for people who are sure they want to be a GP while they're in the foundation program?
Thanks, Mike. Yes, we keep on hearing that it's becoming the competition rates are increasing, but I understand that's not just general practice. I think the most important time is to spend time with the GP, spend time in practice. So if you do not have the opportunity to have a placement in general practice, then see if there's somebody you could shadow or visit and get that experience and that exposure. Because I think there's so many different types of general practice placements out there, but if you can actually understand what the role is, what it involves, and in particular speak to some current GP trainees about what the program is like and what the MSRA assessment that Molly mentioned, what that involves, and really understanding that assessment and how to get the best out of it, and some of the questions and the way they may be phrased. A lot of it might seem like common sense, but if general practice is what you want to do, then that score and that assessment is really crucial to you. So my message would be, speak to the people who have done it or are doing it, or have recently done it, to increase your chances of being able to be successful.
And certainly foundation program doctors can do tasters as part of their study leave. And if you contacted the local school of GP or GP organisers, they would be able to point you in the right direction of somebody where you could be able to go and spend a week or two at a GP practice. It's a regret, a personal regret, that we can't fund more placements for foundation doctors in primary care, more 4-month posts, and I'm sure we will work towards that as time goes on. Thanks, Pavan. That was really interesting insights into being a medical educator in GP, where there are lots and lots of opportunities, and even though medical education often seems to be in something of a state of turmoil, the only thing we can be absolutely sure is that we're going to still need doctors, we're going to still need general practitioners, and there will always be these opportunities to teach and train them. So if you do go on to a career in primary care, look out for those chances. Thanks, Pavan. I'm going to move on to Chris, who is joining us from Scotland. Chris, with Devolve, we talk about National Health Service, but there are in effect 4 National Health Services in the United Kingdom. With devolved health policy to the 4 nations, are there any differences to GP training in Scotland and working there as a GP after you've finished training?
Yeah, so there are a little bit of differences that have emerged, less so in GP training because we're working on a UK basis, but both Scotland and Northern Ireland have a more traditional time spent in GP and hospital posts, which is sort of split 50-50, while in England you probably do proportionally more GP. In Scotland, you do contracted out of hours shifts, so you've got experience working in an out of hours environment, which has been removed from, training in England, so it's slightly different. I think our training practices tend to be smaller in Scotland, so you probably have more of an apprenticeship model with your educational supervisors, and probably, smaller or lesser demand than maybe some of the practices in England. So a slightly different experience, but we were voted #1 in the GMC survey. My postgraduate dean said to say for the experience in GP posts over the last 2 years. So I had to sneak that in. But I guess there is more divergence in the post CCT space since health has been devolved. There is a sort of quality framework that's still adopted in England that was removed in Scotland. So there's been more focus on developing multidisciplinary teams that's been slightly different. And because we're smaller, if you like, there is more relationships being developed between the college, the deanery, and the Scottish Government about what happens post CCT in terms of when you're defined as a first 5 GP and how we can support that with increasing GP fellowships that have been introduced and career starts for both in rural health and in sort of in rural placements, and also health equity, health inclusion fellowships as well. So there's a lot of work going on now to how we support people in the first few years of their post CCT.
You snuck that in beautifully about the National Training Survey results, and congratulations to general practice in Scotland. I mean, you mentioned rural health there, and of course, all 4 nations have urban areas, and general practice is very important there. But one of the differences between hospital specialties and general practice is indeed that opportunity to work in truly a rural setting. What are the particular benefits and challenges, do you think, Chris, of working as a rural GP?
Well, it certainly is a big issue in Scotland, and that we now have a national centre for remote and rural health based up in Inverness, and we've also developed a sort of extra qualification, which is now called the Remote and Rural Credential for developing skills. So remote and rural practices offer, I guess you're seeing sort of generalism in its truest sense, with your ability to deal with all aspects of care. And Molly was talking about the idea of continuity of care. So in a rural setting, that's one of the best benefits of it, is you tend to know your patients very well. You often have a lot of time you can spend with patients. And so that's a huge benefit of working there. However, you are working remotely, and the challenges can be seen as the benefits to some practitioners of dealing with emergency situations. So emergencies in our islands in Scotland are often you are the only person there to deal with it, and you have long waits. There isn't a sort of ambulance that's going to come and rescue you from that. So developing your skills in sort of urgent care are really important in these environments. You might have to wait for the helicopter to airlift people off, islands. You're having to make those decisions, so that can be challenging, but also a huge, something that people find really exciting as well.
And I guess in a rural setting, in an urban setting, anywhere in primary care, you will always be working as part of a team of people who you'll be working with, I guess.
Yeah, so you will all have a multidisciplinary team around you. Obviously, that will be slightly smaller in number in more rural settings, but you do have support, and you obviously have support from hospitals and for advice at all times as well. So the benefits of primary care is that multidisciplinary team that is being extended all the time across all practices in the UK.
Thanks, Chris. And I'm sure if you are, we'll bring some links on screen at the end, and there's some links there if you want to find out more about what it's like working in a rural and remote setting. And it's worth saying, patients everywhere deserve high quality healthcare. And for some people, they will have the skills, knowledge, and attributes that you need to work in that setting. You might not just have found it out yet. I'd like to bring all of the panel onto the screen, and I'm going to ask you one by one, starting with Chris, just to tell us one thing that you love about being a GP.
I was going to give you two, Mike, so I'm going to cheat and give you two.
Two for the price of one.
One is because I'm old. So the thing that keeps you going in career is the thing that scares you, when you start training, is dealing with uncertainty. So people coming in with presentations, you've no idea what they're going to say to you. By the end of training, what excites you, or by the end of your career, it's because of that uncertainty that keeps you stimulated. So no day is the same. People's stories are very different. So that sustains you as a career in general practice. And the second thing I was going to say was just the privilege of just following on from that, of hearing patients' stories, of being able to be part of their lives. And we're so privileged to be in that place. And the thought that you can support and guide people through their challenges gives you an awful lot of job satisfaction. And so they're the two things probably as I'm towards the end of my career that sustain me.
Thanks, Chris. Pavan, one thing that you love about being a GP.
One's hard. I agree with Chris, but I'll try and stick to it. So I'm the kind of GP who probably never runs on time. In my whole career, never have. But that's okay. I love it, and same as Chris. I feel like it generally is a privilege to do this job. I think it's the best job in the world. To hear the stories, be part of the lives, the family lives, the generations. It's a privilege. And I've always felt like I'm not the kind of GP that knows everything or wants to know everything, but I genuinely feel that most patients, not everyone, but most patients leave my room feeling better than when they entered it, and I just love that. But also I feel better for it, and I finished the surgery last night, 8 o'clock, and I wrote down everything I'd seen, and quite frankly it spanned almost the whole of the RCGP curriculum. So that variety, you see it every day, even in that 4-hour surgery. So yeah, best job in the world.
And it's worth viewers thinking about that, in as much as you become super specialist, you see less and less and less variety, and many hospital specialists now will see very little variety. And if that's something that you're really interested in and you really thrive on, then general practice could well be a career for you. Thanks, Pavan. Aisha, one thing you love about being a GP?
I think it's a very difficult question. I would say everything I love about GP. Like Chris was saying, my trainer said to me once, the day you think you know everything, that's the day for you to retire as a GP. And that's what keeps you going. Every time you're seeing a patient, there's a different thing. Everything is so satisfying when you're actually looking after them and they are grateful. On Monday I did a surgery, and my last patient, I had a very busy surgery, and the last patient, as she was about to leave, she just said, "Wait a second, doctor." I said, "Now she's going to tell me something else, and the surgery is going to run even later." And then she opened her bag and gave me a box of chocolates and said, "Just thank you." And just, having that gratitude and the satisfaction, you're looking after patients. But from the other side, the leadership, it allows you to make the change. It allows you to make the life better for our future GP trainees. And I think that's also very important for us and for me especially. Thank you.
Thank you, Aisha. And Molly, you've drawn a short straw, coming in last after all that, but I'm sure there's something else that you can tell us about what you love about being a GP.
Oh, there's probably lots of things. Yeah, I think to link all the kind of answers together, it's just that human connection that you have with people. And for me, just overwhelmingly, it is that continuity of care. I think getting to know patients, who they are, what's important to them. And 10 people can come in with the same presentation, but what they want from that consultation will be entirely different. And I think getting to know what works for patients, what works for them, what's important to them, and really be able to tailor your approach to the patient is just so rewarding. And likewise, they get to know you and they like your style and your approach, and it's that kind of real human connection which makes a difference to them and to me as a doctor. That's what fulfills me. So that's the big one for me. And I guess talking to foundation doctors, we've got to mention no nights and no weekends. That's when you come out of foundation training and go into GP training, that will be your exponential kind of reason for doing general practice. Having said that, there are lots of late nights, so don't take that as a given, but that's got to be in there as well.
I have to say I'm expecting no sympathy, but I'm on call this weekend in my late 50s. So you make a very good point there. Great thoughts. You always feel like sort of writing all these down to quote to people in the future. Thanks to the audience for sending in lots of questions. That's not always the case when we do these webinars, but some really fantastic questions and some quite challenging ones. But I'll share them out and see what people's thoughts are. So I'll start with Molly, who someone asked specifically about being an ACF and how is the time split over 4 years for ACF training, and does it change the amount of time you spend in hospital or GP practice?
Yeah, that's a very good question. And the answer is it can vary in different places. So different deaneries will do it in different ways. The way that it's worked for me is that my ST1 and 2 years were completely the same as all other GP trainees. So I did my hospital placements and a GP placement for 2 years. And then in my final ST3 year, where I'd normally be in one practice for a whole year, instead of doing that, I've just done that over 2 years part-time. So I do 2 days a week in the GP placement and 2 days a week doing my academic, and then I have my training day in the middle. So it just extends that third year over 2 years, but some places do it differently. I think it's important to say that it probably is an added challenge because you're constantly trying to keep up an academic portfolio as well as a clinical portfolio throughout the whole 4 years, attending extra conferences, writing extra funding grants and ethics applications and these things, which you don't get an awful lot of extra time for. So it is a balance. But there are lots of positives that come with that as well. And one of the big benefits, going back to a question that was asked earlier, is that you have a bit more ability to show off during the application process. You have an interview, you have a portfolio, so you can stand out above and beyond other applicants, which when you do the kind of generic application process just with the multiple choice assessment, you don't get that chance to show off all the things you've done. So yeah, although you do put in a bit of extra work, it does give you that extra benefit as well.
Okay, thanks. I'm going to ask Aisha this question, which, as a head of School of GP, are there any pros or cons of applying for the February intake? Because I don't know whether viewers are aware, but there's 2 intakes for GP training, start in August, start in February. Any particular criteria for starting in February? Any pros and cons of starting in February?
I don't think so there is any. I think it's personal preferences, what time you're finishing your senior foundation year. Some do foundation F3 year, so it's just personal preference rather than the program is set in one way. Whether if you start in Feb, you'll finish in Feb. If you start in August, you'll finish in August. So I think that is if there are no other breaks around the program.
So there's no difference in the training
No, there's no
program.
difference in training or opportunities for the trainees starting at different times.
Okay, thank you. A question for a slightly challenging question for Pavan, someone who's done lots of different roles within GP, as you mentioned. What about the role of being a private GP? Do you think that will be more prevalent in the future? Do you think it's the way forward? That was a question asked by Lucy.
Good question. I personally don't do any private GP work. That's a personal preference. I very much believe in the NHS, what it stands for, being free at the point of care, and that's my value that I plan to stick by unless somebody forces me to. But of course, there are private GP opportunities out there, and I've got lots of colleagues who have worked for private providers, but also set up their own private GP service and joint GP service with other GPs. It offers flexibility. Potentially offers a different pay model with that as well, different perks, different benefits, some flexibility on clinic times. So yes, it certainly is an option, and yes, watch this space. I don't think that's in my remit to decide how much that will dictate the future, Mike.
No, or mine either. Lots of possible change under the in all four nations, I think, as we go forward. A question to Chris as an experienced GP, again from Lucy. What time do you start and finish, and do you feel burnt out?
So come to Scotland, Lucy, and then you'll start and finish times will be better. And so yeah, I think my colleagues at NHS Education won't want me to answer this question because I think I've got flexible. I'm working, my career currently is full time with Nest, so I start at a ridiculous time at the morning and finish. I have flexibility of when I finish, so I can change my hours. But I think in Scotland, most GPs are starting at 8 in the morning and their surgeries tend to finish by 6, which is different probably to England, although some of them will definitely be working later. I think burnout is out there for people. I think the career flexibility that you've heard from everybody allows you to change that. You do have much more control of your hours, and I think there's an awful lot going on to support GPs at the moment in this space. So personally, I don't feel burnt out, but I've probably tried lots of different careers in general practice to try and avoid that happening.
Okay, thanks. Aisha, did you want to come in and talk about that?
I just would like to add, I agree with Chris. I think there's risk of burnout, but it like there's lots of flexibility, and the way things are changing in primary care. And as partners, we understand we need to look after our workforce a lot. So there's much more flexibility when agreeing a contract. We have doctors who would just want to do morning sessions, or doctors who do want to do long days. Doctors who want to, GPs who would like to do different things at different times. So because there's understanding, there's more acceptance that you can actually create with your employer. You can discuss and agree a job plan which suits you, and we all know there are a lot of female GPs who would like to look after the children, and I think we respect that, and we would like to support that. So there's more flexibility and acceptance.
And certainly there's lots of burnout in secondary care. There's lots of burnout in medicine generally. I don't think that's unique to primary care, but I suspect that there is a lot more flexibility in primary care around your life outside of medicine than there may be in hospital posts, or certainly that would be my experience over many years. Moving on to a different topic, a question for Molly from Ramat. Are there any other opportunities to develop skills and knowledge in digital health and technology as a GP, especially considering that in England the NHS 10-year plan and there's a real emphasis on going digital? What are your thoughts on that?
Yeah, interesting one. This has actually come up quite a lot in my role that I've so I'm currently one of the registrar chairs at the Royal College of GPs, and this is a hot topic at the moment. So lots of people chatting about AI in general practice and tech. I think it's been acknowledged that this needs to be part of our GP training curriculum because there's rapidly increasing the amount that we're going to be using technology. So I think in your GP training curriculum, if you are to start your GP training, that there will be more and more training and education on that. There are more and more opportunities for like fellowship years and things like that to really develop kind of technology and to kind of get involved in a deeper way if you want to. And I think just even working day to day in general practice, I think we're probably all aware there's lots more conversations being had about technology and tech. And that's one of the great things about working in a GP practice. You're constantly, having coffees and lunches with your colleagues and chatting about what they're doing with tech and how you can better use it. And as partners, deciding how you're going to use it in your practice and what your approach is going to be. So I think that there'll definitely be opportunities increasingly so over the next few years. And that's one of the great things about general practice. If you find a tool that really works and you want to introduce it to your practice and your partners are on board, you can can give it a go. So yeah, I think watch this space, and don't feel like general practice is being left behind. If anything, I think we're really running ahead with the tech that's being used. There's already lots of opportunity to integrate tech into our day-to-day work.
I agree. I think the use of information technology and tech has been at the forefront in primary care, and secondary care has really lagged behind. And certainly a few years ago, a GP friend of mine came to see what I did on a ward round, was absolutely staggered at how we still wrote in the notes with a pen, which, as he put it, seemed terribly and I suspect many viewers, but that's their norm. So I think general practice, and indeed, real tribute to our GP colleagues is how, as someone mentioned earlier, how you managed to carry on working through the COVID pandemic, and it is the huge tribute to primary and secondary care in this country that we managed to carry on working despite suddenly all the sudden restrictions of that. I'm going to finish
just add
with
to that as well. I've actually got 2 GP trainee colleagues who've set up their own health tech business and are doing that alongside their GP training. And I think if you're interested in tech, being a GP and somebody who can code or develop apps or something, you'd be a real resource in the NHS. So you can that's a great career opportunity.
Haven, a last word on this.
Oh, just to say that Mike and we're very much embracing digital and tech from a GP training perspective as well. So for those on the call, watch this space. We are going to be looking at it, using it in all its benefit and uses to embrace and enhance your GP training experiences. So yeah, come to KSS.
Now we've had lots and lots of questions. I'm afraid we're not going to be able to answer them all. So we'll finish with a sort of one which I fully understand is a real concern to foundation doctors, and I suspect lots of resident doctors around the country. And this is from Lou, who said, one of my concerns about a career as a GP are the current discussions around GP unemployment or underemployment. Do you think it's right to be concerned? Perhaps I'll ask Chris to start off, and then perhaps Aisha to come in on that.
Yeah, well, I think in my career there is always fluctuations of where it is harder to get jobs and when it's easier to get jobs. So we're always in a cycle of change. And at the moment, there's obviously been a lot in the press about GP unemployment. I think there's an awareness from the college, government, deaneries about how, to try and work around that and to try and support people. So in Scotland, we're looking to bring in a lot of fellowships to support people post CCT. And I think there will be opportunities for people to work. I think sometimes there is people who are wanting to work in a very specific place, and there may not be that available opportunity at a particular time. But I think there are a lot of career opportunities that are coming up in general practice. So I think it will be a positive. It will be a positive thing in the future, and I think particularly we'll find, and if you start GP training soon and then you do 3 years, that the situation may be very different to how some people are describing these stories now.
Chris, Aisha, your thoughts?
I think I would agree with Chris is saying it's always fluctuating, and obviously it's also depend at what time a lot of GPs are retiring, because we have got when suddenly there's many retirements and there is a vacuum. However, in England, we have got ARRS scheme, which is an NHS funded scheme for primary care, and it actually supports practices to recruit salary doctors through that scheme, and that has been very popular, and lots of primary care networks have been able to recruit. In my own practice, we recruited 3 in August this year, so there are jobs available, and it's just watching out what is out there. But I don't think there is a risk to that. And what I understand from NHS England workforce plan that would be coming in future very soon, I think we're looking at November this year, there would be another GP placement expansion. So with the integrated neighborhood teams expanding, I think there'll be more emphasis on a GP and primary care.
Okay, thanks. Well, I'm going to bring this webinar to a close now. Thank you for all your questions, those of you who are online, live as such. Really do appreciate it. I'm sorry we can't ask them all. If you do have any particular queries, if you're a foundation doctor, I suggest contacting your local GP school. There is one everywhere. And if you're not sure who to contact, if you ask your training program director, if you ask your foundation school director, they'd be able to put you in touch with someone who'll be able to answer your queries. I'd like to really thank Molly, Pavan, Aisha, Chris, for giving up your time, for showing us your enthusiasm for primary care. Healthcare in this country in the mainstream media gets a bit of a kick. So it's really nice to talk to people who can see the benefits of what they do, and can see a career that is been enjoyable. And those who've viewed the webinar have enjoyed it. And as I say, if you have any questions, then please get in touch with your foundation school. There's some links here to the to various information about the different GP training schemes that there are in the UK. So I wish you good evening, and thanks very much indeed for watching.